Good morning, this is Michael Chiang from Boston Group 15, and I'm going to be presenting the FLARE study, which was published in Journal of American College of Cardiology, Cardiovascular Interventions in May 2019. As the title says, this is a prospective single-arm, multi-center trial of catheter-directed mechanical thrombectomy for pulmonary embolism, and being a non-blinded, non-randomized trial, the main statistical interest here is going to be their sample size calculation. Okay, so why should anyone care about acute pulmonary embolus? PE is the third leading cardiovascular cause of death after only myocardial infarction and stroke. And the number of deaths in the US is somewhere between 60 and 100,000 per year. The mechanism, roughly speaking, is pulmonary obstruction leads to right-sided pressure overload, which leads to right ventricular failure, which results in cardiogenic shock. Venous thromboembolism, which is one of the leading causes of PE, is widely prevalent, with somewhere around 900,000 cases per year in the US alone. Also, the economic impact is very substantial at $10 billion US per year. Now, technically, a PE could be anything that doesn't belong in the pulmonary vasculature, making a partial blockage. So that could be a fat embolus, an air embolus, but we're going to be talking for the rest of the study, the rest of this presentation, in terms of thromboembolus, or a blood clot. So what are treatments for acute PE? For those in the low risk category, anticoagulation generally suffices, but for those in the high or intermediate risk, other more aggressive treatments may be needed. These include surgical embolectomy, which is basically open chest surgery involving cardiopulmonary bypass. This works, but obviously is highly invasive and has significant side effects. To try to avoid those, people have tried systemic thrombolysis, where a thrombolytic agent is delivered through a peripheral vein. This works for dealing with the PE, but has significant adverse side effects, including 20% major bleeding and approximately 3% intracranial hemorrhage, which can be, of course, a disaster. To try to get around the risks of systemic thrombolysis, people have used catheter-directed or local thrombolysis, CDT, and this does reduce the number of side effects, but there's still approximately 10% major bleeding, and intracranial hemorrhage is still a risk. Therefore, people have decided to try alternative approaches, specifically in this case, catheter-based embolectomy, where a catheter is inserted peripherally, brought into the clot or pulmonary embolus, and then they try to break it up and suck it out. And that's the FLARE study. Now, most of the stuff we think about in clinic as a medicine doctor, for example, is preventative. Anticoagulation, vena cava filter, and while these can be effective, they are more toward preventing recurrence of pulmonary embolus. This slide just shows the manufacturer's pictures of their device. Panel A on the left is the FlowTriever catheter. This is inserted peripherally through a large bore catheter, approximately 20 to 22 French, and this device is put into the catheter. You kind of mush it around in there and try to break up the clot. The snake-like object in panel B is the aspiration guide catheter, and this is used to suck out the presumably broken up bits of clot. So this can be done across multiple passes, and there are several device sizes, but basically bottom line is you need large bore peripheral access. There are two broad categories of endpoints in the FLARE trial. These are imaging endpoints and then safety endpoints. The primary imaging endpoint is the right ventricle to left ventricle, or RV-LV ratio, at baseline versus 48 hours post-procedure. They also use a clot burden score, which I'm not going to talk about further, other than to say that basically it looks at segmental and subsegmental branches of the pulmonary arteries, and then looks to see whether there is total obstruction, partial obstruction, or no obstruction in any particular branch. In terms of the safety endpoints, the primary endpoint was a composite major adverse event, or MAE, within 48 hours. And this was comprised of device-related death, major bleeding, as defined by the VARC-2 consortium, which is actually a prosthetic valve consortium, device-related cardiac or pulmonary injury, and treatment-related clinical deterioration. The secondary safety endpoint included the primary endpoints plus all-cause mortality, device serious adverse events, and 30-day PE recurrence. You might be wondering why the trialists in FLAIR used an imaging endpoint rather than a clinical endpoint, for example, of death, stroke, whatever. And the reason for that is because the intermediate risk patients, which are the population in this trial, actually don't have that many events. Anticoagulation alone studies indicated a 3% mortality rate at 30 days, whereas observational studies have put it somewhat higher, but not that much higher, somewhere between 3 and 15% at 7 to 90 days. So it's a very heterogeneous set of observations. The bottom line is, because the risk of death mortality is actually relatively low, the sizes of the trials would be prohibitively huge if mortality were the primary efficacy endpoint, or freedom from mortality. So they use an imaging endpoint. So the RV-LV ratio is basically the ratio of the maximal diameter of the right ventricle, shown by the yellow colored line in the picture, versus the maximal diameter of the left ventricle, shown by the green line, on axial contrast-enhanced computed tomography. The normal RV-LV ratio is less than 0.9, meaning normally the left ventricle is a bigger diameter than the right ventricle. In the patient you can see here, obviously it's not the case. The RV is enlarged and dilated. I'm throwing this slide in here because imaging is what I do, so I kind of like it, and also because the reformatted 4-chamber ratio is what was used in the FLAIR study. So the idea here is that the panels on the left show the same patient, and the top left panel shows the maximum RV diameter, the bottom left panel shows the maximum LV diameter. The point is that because this is a stack of images, and because the heart is not oriented perfectly to the CT scanner axes, the maximum diameters can be on different images. Now, because the heart is kind of crooked relative to, or double oblique as we say, relative to the scanner axes, one solution is to reformat the image stack so that you're actually looking at things in standard cardiac planes rather than scanner planes. That's what's been done on the right. The upper right shows the axial view for a patient, and then the bigger picture on the bottom right shows the reformatted 4-chamber view. So on the bottom you can see the thick wall at the left ventricle, and on top the right ventricle. And in principle this is a more standardized view, which is good. It could eliminate variability, but to be honest, there's also another source of variability, because when you do the reformatting, there is some subjectivity involved there as well. But that said, this is what was used in FLAIR and is what is increasingly being used in ongoing trials. So here are the study inclusion and exclusion criteria in rough outline. Basically, to get into the study, you had to be an adult aged 18 to 75. You had to have a CT documented acute pulmonary embolus, and you had to be hemodynamically stable, meaning no pressors, no vasopressors, heart rate less than 130 beats per minute, and a systolic blood pressure of 90 millimeters of mercury or more. And this automatically means that patients are no more than intermediate risk, because pressors, extreme tachycardia, and hypotension or hypotension requiring pressors are definitions of high-risk PE. Exclusion criteria were having thrombolytics within the prior 30 days, having active cancer, or any sort of contraindication to anticoagulation. So now we get to the statistical section of this presentation. In the FLAIR study, you'll recall they had two primary outcomes. One was an imaging and effectiveness or efficacy outcome, and the other was a safety outcome. The primary outcome, primary imaging outcome, was reduction in RV-LV ratio. And they went about this in a somewhat complicated way. They first said that they were expecting a reduction of at least 0.12 based on prior trials by other people where anticoagulation alone was used. Then they went by and said, well, we expect catheter embolectomy is going to be more effective than anticoagulation alone, which is fine and reasonable. They selected 80% power, which is quite standard. Then they calculated sample sizes needed to detect the difference between the anticoagulation results and their expected catheter embolectomy results. And although they don't quite say, they did have some of their own preliminary data in a case series. It wasn't a small trial. It was just a series of patients they had done. And I think this is where they got their expected RV-LV reductions. of 0.2, 0.225, and 0.25. From these, the calculated sample sizes were respectively 62, 38, and 26. In terms of their primary safety outcome, this was a composite of major adverse events. And I found this section of the paper somewhat confusing, so I'm hoping I'm getting this right. I had to read it several times. My understanding is they estimated that less than 25% of patients would have an MAE. Then, based on prior trials from other investigators which used thrombolysis in the trial, they estimated that the upper 95th percent confidence interval for the composite MAE rate based on those 7 prior trials was 16.3%. So basically they wanted to show that their new catheter embolectomy procedure was not worse than thrombolytic trials in terms of MAEs. They selected a very typical 80% power. Then they calculated sample sizes for 13, 15, and 17% MAEs based on a one-sided P of 0.05, and this gave them sample sizes of 70, 103, or 167. So when I read this, I was a little confused initially, but I think what they're saying is that I think their reasoning is as follows. If their comparator is a 25% MAE rate, then if their actual MAE rate is only 13%, they need 70 patients. On the other hand, if their MAE rate is worse at 17, well, that's closer to 25, so they need a rather larger sample size of 167 to differentiate, see if they can differentiate 17 from 25, right? So I think that makes sense. Basically, their comparator is higher than any of their hoped for MAE rates, and the closer their actual MAE rate is to the somewhat hypothetical comparator, then the more patients they need to see if there really is a difference. So what they did is they seem to have decided that they were going to go with an estimate of 15% MAEs for their trial. Now, conversion to thrombolysis would exclude a patient because they were using a modified intention to treat algorithm. And they estimated that about 15% of patients would convert to thrombolysis, so they simply upscaled by dividing 103 by 1 minus 0.15, or 0.85, and this gave 122 patients. Okay, so what happened? Well, let's look at Table 1 first to get an idea of our population. For some reason, they ended up with 104 patients rather than 122, and not clear why. I don't think they did an interim look. It's not specified in the paper, but it's quite likely they did do that. Anyway, the average age was about 56 years, which is pretty typical for PE patients. About half were women, and about 17% were black, and the remainder were basically white. Patients were obese with an average BMI of 36, and about 1 in 7 of them had a prior DVT. About 1 in 10 had a prior PE, and you can see the other comorbidities. The other thing to note is that 59 of 99 patients had an elevated troponin, which is about 60%. So these were actually not people who were very sick with PE. These were indeed intermediate risk patients. In terms of the primary imaging outcome, or the primary efficacy outcome, the study did quite well. As you can see in the figure, the average RV-LV ratio was 1.56 at baseline, and then 48 hours after catheter embolectomy, this was reduced to 1.15. So this was an absolute improvement of 0.38, or 25.1%. So they definitely met their imaging or efficacy outcome. Okay, in terms of their safety outcome, 4 patients had among them 6 major adverse events within 48 hours. 4 had clinical deterioration. In other words, all of them had clinical deterioration, and there was 1 case of major bleeding, and then 1 pulmonary injury, which ultimately required surgical lower lobectomy. Now, their goal was less than 25% MAEs, so 4 out of 104 gives 3.8%, and the 95th upper confidence limit for that estimate was actually 0.86, and both of these are well under 25%, so they very definitely exceeded their safety goal. In summary, FLAIR met its primary goals. The RV-LV ratio reduction was 0.38, or 25%, and in terms of safety, their major adverse event rate was only 3.8%. So this sounds really good. But clinically, the role of catheter embolectomy remains to be defined, and there's a number of reasons for this. First, the improvement of RV-LV ratio was similar to that of catheter-directed thrombectomy, which was 0.34 on a recent meta-analysis, so 0.34, 0.38, not very much difference. It's true that catheter-directed thrombectomy was associated with major bleeding, about 9.3%, and intracranial hemorrhage at 1.5%, versus the current FLAIR study, which was respectively less than 1% and none. So that appears to be a win for FLAIR. However, FLAIR had only a 2 millimeters of mercury reduction in mean pulmonary artery pressure. It's unclear how this translates into a clinical benefit. Also, the patient population was intermediate risk, not the 30% mortality in 1 month high-risk group, but rather somewhere between 3 and 15% at up to 3 months. So it's an important group to treat. It's a very large group, but the bottom line is probably that this FLAIR study is more a proof of concept that catheter-directed thrombectomy can be done fairly safely in a variety of centers, but whether or not it has ultimately the outcomes we care about, which are not imaging. It's not about RV-LV ratio, it's about survival, right? So the jury is still out, and additional trials will need to be performed to evaluate catheter-based embolectomy as a whole. And that's it. Thanks.